Sunil,
Yeah.
should I start? Okay. Yeah. Good evening, everybody. Shubho Vijaya to everyone. Uh, we are inviting everybody for Gemas Surgical Masterclass. Gemas is an organization which is a platform for the surgeon and the gastroenterologist. It was a unique organization which was formed 7 years before when the seven surgeon and gastroenterologists they came together and formed this platform. Our main aim was to continue with these academic activities and also training programs. And we have been doing so over last 7 years. Every year we used to have a gastro summit where we used to have all the lectures from the surgeons and the gastroenterologists of the different parts of our country and even abroad. So this year was a different year. This pandemic has changed our life. And so we thought that we will never stop. We changed our program to our webinar program. In gastromedicine, we have done 8 webinars over last 8 weeks. And this is the first webinar for the GI Masterclass. And I can see all the distinguished speakers are here. I hope that it will be a big success for all the trainees and gastrosurgeons. I will definitely hand over the mic to our colleague, Dr. Dev Kumar Roy, for further proceedings. Over to Dev Kumar. Thank you.
Thank you, Sudipto. That was a good introduction. We're just going to start. I'm just going to introduce our speaker. Today, our theme is laparoscopic TME mostly, total mesorectal excision for the rectal cancers. And both the speakers, they both do laparoscopic as well as robotic surgery. So I've asked Prof to give a lecture on how to do the tips and tricks of TME. Prof Parvez is a renowned figure worldwide. I don't have to give too much of introduction. I met him personally in 2012 when I just went for a brief bariatric course there. And then we had a brief chat, and then since then we are in touch. And he's kindly agreed, taking his time out in a Saturday afternoon to teach us how to do a proper TME regarding using all the gadgets, what he's got. And the next speaker will be Dr. Narsimaya, who is also trained abroad for several years and done CCT from UK in colorectal. And now he's practicing in India in Apollo Hospitals in Bangalore. And he's also a good friend of mine. And he's going to talk, he's a keen robotic surgeon now. So he's going to talk about the robotic TMEs. And we have two panelists here. One is, I don't see Manas. Manas, you're here. Yeah. One is Dr. Manas Rai, who is a chief GI surgeon in Tata Cancer Hospital in Kolkata for last, I think, 7-8 years. And before that, he used to practice in Kolkata only. And he does lots of colorectal dissections, laparoscopic and open. And next is another panelist is Dr. Shivnath Mondol, who is also trained in UK for quite a long time. And he's a established colorectal surgeon for last 7 years, I think, in Kolkata, in Peerless Hospital. So now I'm going to ask Prof. first, Amjad, to start his lecture, share the screen, and teach us.
All right. Well, thank you very much. Good evening, everybody. And thank you, Roy, for a very kind introduction. Most of us have met directly or indirectly through our profession. So it's a pleasure being asked to come and speak to you, be it Saturday afternoon or evening. I have interest in teaching, so hopefully this would be a good few minutes. Right now, I am a laparoscopist or minimally invasive surgeon who has interest in colorectal surgery and who has interest in teaching. That's the bottom line of my introduction, effectively. I have a split life now. I work partly in few of these places. I used to work in Portsmouth for many years before I decided that I would go to Europe and work in NHS on a part-time basis. Now, When we talk of evolution in rectal cancer surgery, the biggest change, most of you would agree with me, have been the mere concept of total mesorectal excision, because I think that probably changed the whole game in terms of local recurrence or local problem. And as soon as the surgeon realized that this fatty package that is around the rectal tube itself contain all the important structures that need to sort of stay within patients, giving them better urogenital function, for example, it reduced the local recurrence or local failure from 30 to 40%, as in Portsmouth as it was. We were actually in Panorama 1988-89. Mike Thompson told me that there was a program called Panorama in Britain, where they came to Portsmouth because we had the highest local recurrence rate in the country following TME surgery, because they wanted to find out what was going on. Now, most of the centers would have a single figure local failure rate. And within most of us, our lifetime, people around this panel and people hopefully sitting in front of the computers would agree that minimally invasive surgery is the second biggest evolution that has happened in our lifetime. Certainly it has shown that you have better short-term outcome and equivalent at par oncology. Now, what are the important strategy for doing laparoscopic TME? I would keep referring in my talk as MIS TME or minimally invasive surgery, because I genuinely believe that laparoscopy, or for that matter robot, is a mere tool. It is not the religion. The religion really is anatomy for me. And if anything I could put across in this sort of half an hour of talking to you is, to young surgeon, learn anatomy. Anatomy holds the key for me. Of course, you need very good radiologist, as your eyes. A very good MR reading radiologist would tell you who are the patients and where the margins are, who can go to operation up front, who need treatment before you could operate on them. So I genuinely believe that it is worth investing time and effort persuading a very good radiologist to come and work with you. You also need a critique friendly pathologist who would keep your feet on the ground, because we as a surgical tribe genuinely believe that we are extension of God's work. I can never have a positive margin because I saw it cutting wide. This is what I used to tell. But pathology and the microscope would hardly lie. So you need a self-critical attitude. You need a pathologist who would keep you nice and straight. And you need an excellent MDT backup if things go wrong or right. Now, I trained around the world. I have a privilege because of my profession, being exposed to different cultures, different languages. But surgical language is very, very universal. You really don't need to speak in a different accent or language. You would see the picture and you would realize as a surgeon, this is a surgical language. People often send me their patients' pictures mainly for approval and sort of say, what do you think of this? This has come from India. Some form of format where people were sharing pictures, and somebody sent this across to me and said, we have just done the first laparoscopic APR. What do you think of this? And most of you sitting around the panel would say, well, it looks okay, except that the stoma is a bit lateral. But other than that, it's probably is okay. But I'm always interested as an oncology surgeon to look at what has actually come out of this patient. So I asked the fellow surgeon that, would you please send me the picture of specimen? And then I will give you a very honest appraisal of your operation. And he did send the picture in all earnest. And most of you would agree that this is slightly suboptimal specimen if you're an oncological surgeon. So I genuinely think the goal really is not to hack it out at any cost. The goal really is that you need to do the operation which would leave patients without their cancers and without complication. And that's where the goalpost is. You ask patients what matters to them, few scars and a stoma or a specimen like that, what they really are interested in. Most of the patients are interested in coming into the hospital, leaving hospital without their cancer and without complications. These are the two things they are interested in. And of course, now we are not only wanting to live longer and longer, but we want to live better as well as longer. So functional outcome have become a centrally important thing. And this has repercussion why we are trying to do it laparoscopically, robotically, TME, open surgery, because we're trying to find a perfect solution. So organ preservation or nerve preservation is also a key. So I generally think that MIS approach, regardless of whichever way you do it, it offers you precision and lower conversion rate. It provide an access to difficult bony pelvic access area. Now, I get asked this quite a lot, and industry, because I work with robotics for the last sort of 7, 8 years, and industry have this constant thing going on with me that they ask me to come and speak in different symposiums and everything else. The message they pretty much want me to say is that there is a button that you could press, and that button would do Bill Heel's operation on a robot. Unfortunately, it will not do that operation. Uh, a difficult operation remains difficult no matter how you do it. It probably become less difficult with appropriate tool and better training. But if anybody gives you this notion that prof have taught me this is very easy through this way, they probably are making it up, because that's not true. Better short-term outcome in high-risk patients are also seen. And I think, if anything you can take away from MIS surgery, it provides a perfect platform to teach and train people. That's how it has played a central role, in my view. Now, I don't need to share all of this. A number of trials have shown that this laparoscopy is safe for colon cancer mainly, although the classic trial in England, where most of us work, showed there were some problems with higher positive margin rate, higher conversion rate, and so forth. But people expect either laparoscopy or, for that matter, robot to produce a different outcome. Everybody asks me, show us this is better. And my argument is very simple. Why it should be any different? The biology of the tumor stays exactly the same. The anatomy of Homo sapien stays exactly the same. You just need to do this using different tool. This is a slightly older slide. Some of you must have seen this previously. This is a HAS data looking at elective colorectal cancer resection through laparoscopy in England, 55%. Now we've gone up to about 68%. This is for colon and rectum with 10% conversion rate, national figures. Remember, this is self-reported data, and we often sort of self-reported data is slight prejudice and bias because we tend to overestimate our ability. This is a problem not only for laparoscopy. This is a problem for open surgery as well as for robot surgery as well as for TME, regardless of what my colleagues tell me that this is very easy in a male obese patient with big prostate from below. I have not seen anybody do it very easily. I have seen them do it well, but they all have struggled. Now, this is a la carte trial. You probably are familiar with this. These are publications who came very close to each other in JAMA, one after another. And this was the first time I heard the word non-inferiority in clinical trial setting. More or less what it means is that laparoscopy specimens were inferior in terms of quality as compared to open surgery. Americans did exactly the same. Some of the really big names are on this paper who are very well known in colorectal circuit around the world. And one of them, actually, Steve Wexner, was talking to me in Moscow a few years ago when we were talking about laparoscopy and robotics, the usual debate which you often have. And I asked him that based on the clinical evidence that you have published, this is level 1 evidence, randomized control trial, where you are saying that laparoscopy is bad, where your laparoscopic tuber or rectal perforation rate is 15.5%. If I have a 15.5% specimen perforation rate, my MDT would stop me doing laparoscopic surgery. So I said, how come you justify this? Have you stopped doing laparoscopic surgery now? And of course, he said, well, Amjad, it was not me. It was some other guys, And that's the real good thing about being a surgeon. There is always someone else who does it badly. The truth is, most of us are average, and that's the problem. If you look at American practice in general, by and large, we know 1 or 2 big names or centers, but most districts do 10 to 12 rectal cancers a year. It's the repetition. Now, is based on these trials and data and everything else that have come through, is laparoscopy all that bad? I generally think that operative technique, if it is standardized, it is driven in specialized center who have relatively high volume, people can do it better. Korean did it better. All my life, we all have been faced with this. Whenever this data is shown to us, we always say, but they are different patients. They are slim patients, and they are Japanese, and they are Koreans. But the anatomy is the same. If some of you have gone and actually watched these guys operate, they operate as a religious practice where they do it precisely, they take their time, they do high volume, same operation over and over and over again. And that's why they become good at it. This is Korean trial looking at mid to low rectal cancer, T3 onward, post chemoradiotherapy. Good trial design. looking at no follow-up lost patients, looking at conversion rate of under 2%, 3% CRM positivity rate, no difference in terms of overall survival, disease-free survival, and local recurrence rate. So, of course, they could do it better. While we were struggling in the West, sort of blaming it on classic trial and blaming it state instrument of laparoscopy and so forth. The key really is this. The key really is we failed to standardize operative technique. We failed to standardize what laparoscopic TME would look like. This is our work, over 2 years worth of work, where we are trying to get an international consensus. It was very difficult for people to come to any consensus, but this is where it started many years ago. This was the work of all those seminars and workshops of TMEs we did in late 2000 and early 2010 or 12. This is data from my own practice, looking at standardized approach to lab TME. And the idea really was this. If you look at it, 5-year survival, 83%, stage by stage survival, pretty decent. Under 1% conversion rate, CRM positivity rate 2.8%, and local recurrence rate of 1.4%. And this, I found it very difficult to publish it in BJS, because everybody keeps telling me this is fantastic data, but this is a single surgeon, single center data. It is not reproducible. This is a British way of sort of saying we actually don't want to publish it. Now, then I took 3 of my fellows who worked with me at the time, and I looked at their independent practice after they left Portsmouth. These are those 3 individuals who left Portsmouth working with me, and look at their operative, long-term outcome, short-term outcome. And initially, I thought I was something very special, but to my disappointment, I learned that they could reproduce the same results. Why it should be any different? So it is possible not only to do it, but to actually teach and train people doing it the same way. This is where the real crux is, and I really hope it works, because, okay, this is where the real crux is. Anatomy is the key. If some of you have a chance to come and work with me, we have spent awful lot of time in learning anatomy, doing open cadaveric dissection with a colleague and a friend in Ankara, Ayhan Kuzu, who produced beautiful videos of anatomy. He was an open surgeon who converted to laparoscopy after seeing me in Vienna. And then he asked me to come and do these dissections in open cadaver technique, but do it in the steps of laparoscopic TME, so he could reproduce the anatomy the same way. So, you do the back first, for example, in TME surgery, then you do the right side, do the front, the left, and he just reproduced these. These are beautiful videos, which for years have been freely available to trainees, to go back to. I do an operation, I go back and look at these videos, and I quietly know what I have done wrong, because I have not done a perfect operation yet. There is a long way for me to go. But it's the key really is your ability to self-critique yourself, and that is important. Learn from anatomy and then self-critique your techniques. Now, because this is mainly a surgical forum, so if it is okay with your permission, I'll show you some short videos.
Yes.
And then talk to you about some practical aspect. And then I know Sima is going to cover robotic surgery, but because I do more and more robotics as well, and with your permission, I can show you what the similarities are. The tool is different, but the anatomy is the same. Okay, this is a standard operation. This video hopefully would play. This has been around for a while. Some of the guys have presented this in few places. Now, this is without chemoradiation, a male patient, straightforward operation, but it is really meant at trying to dissect out the modules or the steps. I'll let it run fast if I could. Okay, so I'll stop here. Now, this is the standard port placement for all left-sided dissection for me. If it's a sigmoid, rectosigmoid, APR or TMEs. APR, probably I won't put this extra 5 port at the top because this is for splenic flexion mobilization. What I didn't show it very well here is the line you put these 2 ports in. For example, this is 2 finger breadth medial to the anterior spherical spine. If it's obese patient, I bring it a bit more medially because it's the pelvic right side wall, which is a rate limiting step because you have straight instruments to go in. But try to put this 5 millimeter port not in line with 12. So 12 stays out, 5 stays in. because otherwise your hand would become parallel when you're doing the pelvic right side wall. You don't want to have a chopstick effect when you're doing the right pelvic side wall on obese patient. So you want to have what I call the triangulation effect. Laparoscopy works better when we have a triangular approach wherever we are working. Camera stays here. This is assistant port. So this is the standard setup for me. This is not the only way to do it. This is one of the ways to do it as long as you get exposure. I start, like most of us, medial to lateral approach at sacral promontory. Some people start under the vein. It's no different. So I start with monopolar diathermy hook. You can use any energy source. I don't have any prejudice about anything. The reason I use hook is I generally think that if I'm wrong using a monopolar diathermy at a 20-watt setting, and if it bleeds, it only means one thing, that I missed the anatomy. It means nothing else. Other energy sources are very good. They almost sort of are too good. It doesn't make you realize once you're out of the plane. Now, there is an air that tracks in after the first incision onto the peritoneum, and there are two levels to the air, the top level and the bottom level. The air runs at the back of the vessel. This line, if I follow this here, would take me to the right iliac artery. The top air is the one that would take me behind the superior rectal artery, and then I would follow it up going northward. As soon as I start, I always go south as a habit first, because I want to see the smooth package behind superior rectal artery. In slim patient, it's very easy to demonstrate this. In obese patient with a lot of visceral fat, sometimes it is difficult. The problem is, if you have a big loop of sigmoid, it is very easy to start above the vessel and convince yourself that you are going absolutely fine. I have done that. I have made that mistake. If you do enough of these, you would make that mistake. What is consistently positive or consistently there is the back of the mesorectal plane, which is always there even in obese patients. So I always go south first, slightly before I follow it back north. This is just the tip. Again, hook just very precisely. If you see this, try not to push with a hook, because pushing with a hook is a pointy instrument. You can make things bleed. If you want to push, use some energy source, some blunt dissections, whichever way. Again, if you can name the arteries, you should clip them. You will sleep better at home. I have a very simple concept. On the left side, I try to clip one artery and one vein. There is no oncology debate about it. This is not one is better than other. This is easier. If you're trying to do a distal ligation, then you have to dissect quite a lot in this triangulation, and the IMV, as you know, run in this triangle just above the takeoff of the left colic. So that's much more work for you. This is easy. The only thing is to look out for this plexus, the hypogastric nerve plexus, not to go and burn at the root. Take it centimeter and a half from the trunk. Always leave your get out. Always leave the get out clause. If you dig deep thinking, Prof is leaving this lymph node tissue here, he could have been a bit more here, and you run up with a problem where the junction of the aorta with IMA is, this is game, set, and match for you. So that's why I always leave the get outs. Okay, I clip the vessel, and then you can cut it. Preferably you put 3 in. I don't know why I put 2 on this case, because I think they were asking us to show this thunderbeat, but 3 is better. 1 for you, 1 for the patient, and 1 for the lawyer. Now there you go. Medial to lateral dissection, white line of Gerota's fascia. I dissect under the vein, and just when you divide the vein, you will see the pancreas from below. So going from medial to lateral from underneath, it's very easy to go behind the pancreas. So once I see the pancreas, I drop the pancreas down, I leave the gauze at the top of the pancreas. Half of the time, you are able to break through into the lesser sac. If it does it, great. If it doesn't, don't sweat too hard, because sometimes with previous pancreatitis, the obliterated lesser sac is not easy to get in. But as long as the pancreas come down, and I'll show you in the next video how you bring it down, you leave a gauze over it. The reason I use the pancreas as a marker, as most of you would know, is that staying at the level of the upper bottom of the pancreas is making your marginal artery safe. You are less likely to damage the blood supply of the splenic flexure area. So you're staying low. You are doing what you call a complete mesocolic excision. Now is the lateral mobilization. Again, air is the junction of yellow and white where you choose to divide. Then I go above supracolic, look for the bruise. I burn onto the bruise to look for the gauze that I put in at the top of the pancreas. And now I follow this line, which is the line joining the two ends. So this is how I mobilize flexure. On the left side, I mobilize this flexure on the right side and right hemicolectomy by putting a gauze on the duodenum. Same principle, really. The organ changes. Now I focus on few steps of the TME. I do the back first a long way, and I can put a small counter traction hand with a little pledget or at the back of the specimen, and you could see it's the yellow side of the white that I want to burn or paint, what I call a reluctant painting. Really, you want to do the back of the hook. You got to enjoy doing this. It's not a punishment. There are other ways of punishing yourself rather than surgery. So if you think that you should do it fast, because then you are in the wrong profession. These 3-4 hours are the most important 4 hours of your patient's life. So, this is the least we can do. This is 4 of the 10,000 hours that any of you would be operating on. But for the patient, these are the most important times. So I always slow down and I try to do. I don't succeed all the time, but I try. So look, right hypogastric nerve plexus coming in. It really has to be teased away from the specimen. So it's almost sort of like sticking on the surface of the specimen. You just need to let it separate. I don't have to cut the trunk, don't have to cut through anything. I use the yellow diathermy pedal, 20 watts, traction, just repeated painting. This is the 5 millimeter port. The assistant is putting a counter traction on, taking the air. Air holds the clue. It is a bit difficult when you have a radiation because the air disappears with radiation. The smoke become a problem with radiation and monopolar. Now, left side, again, how do I know where to go? I look at the shape of the specimen. The shape of the specimen, the left nerve going away from me, and I just go at the top of where the nerve comes in and just wait for it to disappear. The front in male patients, I use a straight proline stitch, like a hitch, what I call the peritoneal reflection here. There used to be, if you remember, a T retractor, which a T-shaped retractor cost 1,000 or 1,000 euros, I remember. And the guy brought it to me and sort of said, this is what Joa Loa is using and we should incorporate it in our practice. So I decided to hitch the stitch just because we were doing it for uteruses. It works absolutely fine. One of the practical things about putting this hitch suture is that in a obese patient with big bladder, when you put the stitch on, the tent becomes too narrow. That's the problem with big bladder and floppy peritoneum. In those patients, I put 2 stitches on each side. So you almost want to create what I call a rectangular shape rather than a triangular shape. It is just a tip for purists. Again, the assistant is holding a pledget at the back of the prostate, and you got this cuff outside the denovelous fascia, and you are just going further and further away under view. Left nerve again. How do you know this? Because you want to look at the rounded shape of the specimen and gently paint with the back of the diathermy hook. There you go. You're going all the way around it, following the air. Now, have a look at this. This is interesting. This is the right nerve coming in. And if you just focus for a minute, what I'm trying to tease away is the neurovascular nerve plexus here. Look there. Inside these nerve plexus, then you're looking with a 30-degree scope, looking upward and looking at the anococcygeus almost, where you are all the way there. Now, this is interesting. Andy King used to ask me, who was my registrar a very long time ago, a funny guy, sort of said, when do you stop, Prof? And I said, when you reach the pelvic floor. And he said, how do you know that you've reached the pelvic floor? I said, it starts twitching like it is twitching now. If you notice that with each burn, it twitch. And he said, if it start twitching, that you should stop. And he said, whose pelvic floor, patient or surgeon? So I said, whichever twitch first, you should stop. And I think that's the key. Unless you are down all the way at the level of anococcygeus, you haven't done a TME, in my view. This was a problem early on in our experience of laparoscopists, that we didn't go and release the lower 5 centimeter long enough. And that's why we were firing multiple stapler firing, trying to get across this. And that's why people were publishing 17% anastomotic leak rates. Norman Williams, if you remember, published an editorial in BJS saying there is a no man's land that exists in every male pelvises. I really have not seen a no man's land. You can actually go out from above, as you probably have done this all of your practices for abdominoperineals even. So that doesn't stop you. Now comes the stapling. You are all the way down the meso finish. You come onto the rectal tube. You can see the pelvic floor on each side. Now the stapling. Now stapling business was interested for a very long time, and people, if you think about the physics, you have a 12 millimeter port coming next to the anterior spherical spine, and if imagine you want to divide the tube going from the side effectively, you would always have a 45-degree angulation, which means you would have an oblique staple line. That's the problem. Now I go in and I rotate my hand, so I divide it from 12 to 6 o'clock. And if you try doing this in male pelvis with 60 millimeter stapler, you'll end up doing 80-90% of the cuff, and then you'll have a dog ear to deal with the second firing. That's the weakest spot. If you look here, instead of putting a suprapubic port, I use the same port, rotate my hands in, and it looks pretty much like this from the side. In animation, hopefully you'll be able to see this there. Now, this is the problem, that this space below in male pelvis is not a lot for 60-degree to sit. In female pelvises, you are probably able to do it in one firing. So what I do is I divide them intentionally with 2 staple firing, so the 2 meet halfway, and this becomes the weakest spot where the spike would come closer when you do a circular stapling joint. So this is just to give you an idea. Hopefully it would work. There you go. You can use any stapler depending upon which company is sponsoring your course. It makes absolutely no difference. I genuinely think most of the products are very good. They work. I use a 45 millimeter stapler. After you've done either a rectal examination or a flexible endoscopy to ascertain the lower border of the tumor, here it is, and it's mid-rectal tumor they're dealing with. 2 firing. Again, 1 and 2. And this is the real clue. Unless it is released posteriorly from anococcygeus, you would have difficulty trying to go into. So you must do this religiously each time you're trying to do the TME surgery. And then you would know what I mean. So you have this firing and specimen would come out. So have a look at this. Specimen comes out, and then you go and do the joint. So this is what I was, I'll just sort of go in. This is important step for you to see. And here, okay, never mind. You got the idea, so take it out. I don't know why it didn't work. It might work here now. Maybe this is different patients. Anatomy again. This is what I meant. When I start, this is somewhere in Serbia recently. These videos are not very edited. I'm really sorry, but you'll get an idea. So I always go south first. This is the point I was trying to make. I don't know whether you could see the picture or not, but there, that's the back or the side of the mesorectum. That's the clue that you are looking for. Again, even the energy source change, for example, here you have a different energy source. See how precisely you do it. You are doing adequate lymphadenectomy using the front half of the instrument, not like big chunks. So you almost you need to know your tools. In the famous word of Brendan Moran, a fool with a tool is still a fool. So it doesn't really matter if you give me a robot. If I haven't got a clue what to do with a robot, I would have all my mistakes in 3D high definition for everybody to see. That's the problem with minimally invasive surgery. So I move it forward again. Now, this is, Sima would cover this very well, but I just wanted to put it into the context. These are 2 different pictures, 2 different patients, same step of the operation, different tools. This is laparoscopy, looking for white line. This is robot doing the same thing, medial to lateral dissection. If you look here, the operation and the anatomy doesn't change. You have a white line that you are looking for. Here on the laparoscopic side, this white line here holds the card, and it has to be brought down onto the floor. Again, and here with the robotic system, the same white line is being brought down with a paint-like movement because the view is more static and the assistance is easy in a way. So anatomy is the same. That's what I'm trying to put across to you. Don't sort of think that one day when Apollo Hospital or the number of very famous hospital in India would buy me a robot and I'd be able to reproduce this. No, you really don't need for this. This is another patient, for example. Back again first. These are lap TME. I'll focus mainly on this particular aspect for you to see. Again, doing the back first. Yellow side of the white. It's almost like a reluctant touch of the back of the instrument. So you could see this. Don't do both side at the beginning. If you do both side of the rectum at the beginning, specimen start rotating and it become a bit confusing for a simple-minded person like me. So I do back first, right side, mark the front, and then release the left side. So this is same way as I teach. So again, traction, counter traction, and then painting in the front. I'll move it forward because most of these videos you have seen. Now have a look at this. This is the nerve plexus. You stay inside the nerve. Back holds the clue to the TME surgery. So you do the back first a long way because then that becomes your reference point. You are operating between the two nerves posteriorly. Again, going forward, nerve here. And you just have to be patient. You just have to respect this for this to leave the specimen. There's no point forcing it. It's the labor of love, effectively. You take your time painting it, teasing it away from the specimen before it opens up the space for you, just like this. Now, again, left side. You saw me do the left side in the previous patient. It would be exactly the same way you do it in this patient. Again, releasing the nerve just off the package, then following the nerve, going with a rounded shape of specimen. Again, very, very boringly similar way of doing it. No difference. Again, doing the right side, and now you have the Denovellius fascia in front. You stay outside the Denovellius fascia. If it's anterior tumor, you cross this very early. If it's a posterior tumor, this is the left nerve plexus. You go forward. Again, robot, same Denovellius fascia. Laparoscopy, same Denovellius fascia. Interestingly, that's the good thing about being Homo sapien. We have a perfect model to do this operation. So it really doesn't matter whichever tool I have, you need to be able to demonstrate that. You are dividing the Denovellius fascia now with a robot. Again, two staple firing, as I said in the previous ones. You could see the Denovellius fascia being divided here. Double layered fascia, one behind the prostate, one on this side. Same thing. It could be Lisbon, it could be India. It really doesn't matter. Anatomy holds the key. Anatomy is the same, regardless of wherever you are. It doesn't make any difference whatsoever. So the idea really that I'm trying to put across to the surgeons listening into it, particularly young guys, is learn anatomy and try to explore anatomy and try to do it as what I call purposeful practice to reproduce this operation over and over and over again. Laparoscopic TME, big obese guy, post-chemotherapy therapy. Specimen looks as it should look like, complete. On this side, no radiation, same operation that I was showing you, complete specimen, presacral nerves, intact presacral fascia, staple line. Same again, you must have seen all of these, most of these. This is in Doha recently, Advantage, okay, locally advanced rectal cancer. They had a robot, okay, give us a robot, we'll do it. Again, I hope it works. This is anterior tumor invading the back of the uterus. The tool suddenly become better for me to do it. Anatomy stays the same. Do the back a long way, sides afterwards, tackle the anterior problem, which is the uterus. So en bloc hysterectomy done using the same tool. Okay, so the guys asked the gynae guys to come in, and they sort of said, we've never done this robotically, but we can help. I said, great. So tell us which artery goes where. And they sort of said, keep telling me that ureter is only 1.5 centimeter away from uterine vessel. So that was the contribution of my colleague in this operation. So they keep telling me the distance, although I could see it. Here it is. But the problem is this, the problem is that we get so absorbed trying to think that this has suddenly become a different problem. We forget that anatomy is a similar, no matter where you're doing it, whatever tool you're using it. So again, gone a bit further. Now gauze into the vagina, cutting right onto the gauze, just like this, and then the back wall, and then staying parallel under the wall to complete your TME. And then take the specimen out through the vagina, close the vagina, and do the anastomosis as you would expect it to do. So can robot improve? Of course it can, because it's a better laparoscopic or minimally invasive tool. But it would only improve things if you do things with purposeful practice. Standardize operative technique, explore anatomy, and then after all this, the gains would be really marginal. You're not going to improve your 1% conversion rate. You could make it 0%, great, right? You're not going to improve anastomotic leak rate because the leak is the nature of the beast. The tool become different, so the gains would be marginal. The idea is this, that regardless of whichever tool we use, these are different part of the word, different way I've operated on. It makes absolutely no difference because what tends to come out of the patient has to look consistently same. And I think that's the message out of my talk. Seeking anatomy and precision should be the goal. Operative technique needs to be standardized. I, all my life, have traveled and looked toward big names, trying to learn one magical thing they would teach me, and I would become a perfect surgeon. To my disappointment, I've never seen anybody show me anything extraordinary. But one thing, what they did do, who were better than others, they did little things right. They had attention to details. And I think that's what makes the difference when you look at it. Marginal gain through purposeful practice. I'm really grateful for you to having me. This is a subject close to my heart. I can speak forever, but thank you for giving me this time to talk to you.
Thank you, Prof. That was great. I was expecting it anyway, so I'm not very elated either, but fantastic work. I think we should go on to Sima now
Yes,
for
sure.
his talk, and then we'll discuss a few points, questions from the panelists. Okay? So Sima, Figo, start yours. Sima?
Yeah, I'm just coming.
Yeah. Okay. In the meantime, I just ask one question to Prof. That do you do TME low resection for any location of the tumor? If
Yeah.
it's upper rectum, mid rectum,
No.
or
So,
no?
so really, my approach to this is very simple. If it is a functional and anatomical requirement where the sphincter can be saved, then I would do it with a minimally invasive approach. We have done functional APR when it is no interest of the patient, trying to give them perineal colostomy, for example, or I'm not desperately trying to cut across a sterile margin at the top of the sphincter, which was pre-radiation clearly involved. So although you are giving them what you call YPTX at the time, but you know they're going to have a local recurrence in a year or two. So that indication has not changed. So if the radiologists tell me that it is clear of oncology on the sphincter complex, and the patient tell me they are prepared to accept the function, then technically it is possible to do it either laparoscopically or robotically. So this is my default approach for any cancers. I have not had a pleasure of doing an open TME by design since 2007, so almost I've forgotten how to do it. I probably would ask my colleagues to come and help me.
Right. Professor, thank you for an excellent presentation, as usual. And I'm grateful to share the platform with you, Prof. I cannot say more about you. You've been a mentor, a trainer, a teacher, and above all, probably my elder brother. To me, I've seen life to an extent, and I think you've made a change to the way we live and we should live. I'm really grateful to you, Prof, and thank you for having me on the podium.
Thank you.
Deb, I'm grateful for the opportunity. And there's a nice say that my grandfather used to say: listen, son, the day you think you've learned enough, I think you're ready for the grave. So I think learning is a lifelong process. And I think making mistakes is very human, because we cannot be divine not making mistakes. And I think that is where I start from. And I'm still in the learning curve, and every day I'm still learning. So when you asked me to speak about robotic colorectal surgery, and when I saw Prof on the panel, I thought, what am I going to say to the panel? Because every bit of what I've learned in minimally invasive surgery has some amount of flavor that has come from Prof. So I'm really grateful, and I'll just put my thoughts across, and learn from the elegant crowd we are attending to. Robotic colorectal surgery. I think Prof knows my story, and in fact, it was him who drew robotics into me. It was him who actually got me to go to Lisbon, spend about 4 months with him, and literally every step of it has been him. So thank you, Prof. So what I have done in Bangalore is come and set up a robotic colorectal surgical unit, and I've called it as Mona Lisa. I think if you actually look into the whole business of Mona Lisa and compare it to the Da Vinci, I think there's a lot to be said about. I truly do not have any disclosures apart from being a key opinion leader for some of the companies. And we'll talk a bit about evidence-based robotic colorectal surgery. I think this is where Mona Lisa comes into picture. Prof rightly puts it. Surgery is an art. I think you have to enjoy what you do. You spend 15 years, 20 years to do what you want to. So, what's the big rush about? I think you need to enjoy that art, you need to enjoy that painting. When it comes to precision, no doubt, robotics is there within the last 15, 20 years. But when you see people like Prof doing it, there is no major difference with the precision when it comes to robotics or laparoscopy. But I think the robotics makes up for the lacunae in the laparoscopy, except a few technical points. So with the Da Vinci, there is a appreciation of depth. The range of movements are a lot more. The vision is superb, and it is truly comforting for the surgeon. No doubt it's a costly affair, and with time, I suspect it will come down. A touch of features about the Da Vinci: 7 ranges of motion, as described above, and about 540 degrees of motion. So it can truly go 1.5 round on itself, which is not possible with the standard laparoscopy. Where does robotics score compared to a standard mediocre laparoscopic surgeon or laparoscopic surgery? I think a narrow pelvis is certainly a place where robotics can help you. With those degrees of movement, the micro wristed instruments, the magnification, a stable platform, I think it truly can make a difference. With my limited experience, when you start doing a laparoscopy, you always struggle at that 1 to 3 o'clock position where you are actually closer towards you. And when you look at the pathological specimens, which have a CRM positivity, they are more towards that area. I think it is a difficult area. Getting access is difficult because you have to look back on yourself. The traction has to be adequate. And when you're seeing Prof doing it, dropping down the nerves from the specimen, you always say, wow. And in a difficult pelvis, it's always a bit difficult, I think. And for a surgeon sitting on a console, I think there is ergonomic comfort. So, as Prof was reiterating, I think it's always a stepwise approach we go. It's the same thing, repetition again, again, and again. So I follow the above stepwise, maneuvers for an anterior resection, and I hardly deviate from them until and unless I'm compelled to. So when Deb asked me to give a bit of an introduction or bit of an overview of the difference between laparoscopic and robotic colon and rectal surgery, I was just looking through some literature, and this comes from Matthew Albert from the Advent Health, where my previous boss John Monson is a part of it now. To summarize in one slide, robotics scores equally to laparoscopy when it comes to short term outcomes, oncological outcomes, and long term oncological outcomes. So that part is taken care of. What about the perioperative morbidity, the anastomotic leaks, and the postoperative ileus? Even there, robotics scores as good as laparoscopy. The oncological parameters such as the lymph node yield, as good as laparoscopy. The CRMs, as good as laparoscopy. Where do robotics really score compared to laparoscopy? I think there is certainly good evidence to tell us that there is much reduced conversion to open procedures from robotics compared to laparoscopy. That could translate directly and indirectly to some economic savings and benefits. Once a conversion happens, we know that there is some evidence to say that the oncological benefit is lost, the length of stay is extended, and the cost benefit is lost. So I think that is where robotics might save economically when it comes to reducing the conversion to open procedures. And also, there is some evidence to say it is equal certainly to the length of stay with laparoscopy, and at times maybe much lesser. The downside of robotics being increased operating time. But if you see people like Professor as well as a few other colleagues around the world, their operating time with the robot is as good as or even better than the laparoscopy, I must say. Again, being on a learning curve, now I know I can dock the robot in about 12 to 15 minutes. And you can get to a stepwise process. And when you know 2 hours into the procedure, I should be at the splenic flexure mobilization. So I think you certainly get better with time. There is a cost implication for a patient, especially in a country like India or the Americans. However, when there is a national health service, it does cost the healthcare services when we are using a robot, at least for the foreseeable future, I think. So I certainly think, there are good amount of advantages or number of benefits by using robotics. It is certainly a safe and feasible alternative to laparoscopy. In the big obese patients, I think it is certainly a useful tool. Low rectal tumors certainly will benefit from them, including the anterior ones, and needless to say, the male patients. But what are we lacking on the robotic side? But as time passes by, you actually compensate for the haptic feedback. You say, I don't have the feel. But as time passes by, you'll realize that there is accommodation of the haptic feedback with the visuals. There is limited range of movement of the robotic table itself. Repositioning of the surgical beds. I think people have come over it because you have got auto movement beds now, and you can certainly make up for that. And what is most important but forgotten is having a skilled assistant who knows the exact steps of the procedure and helps the console surgeon to deal with the procedure or to do the procedure skillfully. So a bit of evidence which I really looked at was from Matthew Albert, as well as looking at the Rollard trial, and also some amount of colonic literature where they compared it with the robotic right hemicolectomies, and more or less it was the same points which I mentioned for robotic rectal surgeries. But one thing to mention about the Rollard trial was there have been extensive criticism about the Rollard trial, but I think what should have been also looked into was the functional outcomes. Time will tell, and I'm sure Prof would agree on that, that the sexual function, the urinary function, the bowel function, the amount of anterior resection syndromes certainly have got an implication to do with the preservation of the nerves. So I think yet till now, I don't think we have looked at the functional outcomes with minimally invasive surgery, comparing it to open, or again comparing laparoscopy to robotics. So I think without further ado, what I would like to do is maybe run through some videos, not as pleasant, not as good as Prof's, but I'll try and do my best. So I think what I thought was run through a stepwise approach for a robotic anterior resection, and then move on to what I thought I should share is a splenic flexure mobilization from the medial side. So if you can give me a minute, I'll start playing the video. Volume है क्या? I think, as I mean, you've seen a fantastic demonstration of. So I thought, Prof has taken us through demonstration of different TMEs in patients with different clinical scenarios. I thought, as a trainee, as somebody in the learning curve, the second thing we struggle with is the splenic flexure. So, in India, the situation is slightly different compared to the West in terms of the number of cases we do. I think the left-sided resections are a lot more, at least in the tertiary setup like ours, compared to the right hemis. So I thought, maybe it is good to demonstrate a medial approach to the splenic flexure, and the demonstration of the video is as shown.
To splenic flexure mobilization. There are a number of ways for splenic flexure mobilization. Medial approach is one of them. Following a modular stepwise approach, the DJ flexure is identified and the inferior mesenteric vein is seen. In this case, the inferior border of the pancreas is easily seen as shown. Once the anatomy is identified, a breach in the peritoneum is created, thereby the process of skeletonization of inferior mesenteric vein is started. It is individual preference whether you would like to keep the inferior mesenteric vein so as to give enough traction to create a tent under which we can get access to the lesser sac. I prefer to take the IMV majority of the times so that there is no traction related injury to the inferior mesenteric vein. In this case, inferior mesenteric vein is preserved till the medial mobilization of the splenic flexure is undertaken. The key point to note is to stay above the inferior mesenteric vein, and a combination of blunt and sharp dissection will show you the right plane to be in. Gentle push and occasional sharp cuts will take you to the lesser sac. It is easier to gain access to the sac the more lateral and distal to the pancreas you are. A gentle traction or the pancreatic covering would also help in giving that traction counter traction. One can see the lesser sac at the distal end of the dissection. As much as possible, the residual adhesions around the area are released and a swab is generally left so that it can be identified from the other side. Inferior mesenteric vein can be taken after the medial mobilization. Supracholic mobilization is the second stage in the process where the omentum is dissected off the colon. We try to do this till the midline, followed by lateral mobilization to give us enough length for the left-sided colon.
Thank you. So I thought for me, the difficulty with the splenic flexure has always been an issue. So repeatedly doing the same medial approach has given me some amount of confidence to do it as the first step of late. And I think as you do more, probably you get better at it. And I cannot agree with Prof. more the issue about the anatomy. See, I did a bit of a work on the precision-based colonic oncosurgery based on the vascular mapping. I did more so for the right colon and even for the left colon. I remember Prof telling from the training days that when you have to do a left-sided resection and anastomosis deep down simha, you have to take the IMV twice, one at the origin and one always at the DJ. And these little tips always help you. And for me, I always skeletonize the IMA and always see the ascending left colic before I take any action or act on. I've got a few more videos to show, as well as a complication I had in the recent past, which I'm happy to show. But I'm not sure whether time is a factor or we can carry on as we are there.
I think we're a bit tight now because it's 1 hour already. So I don't know, if you have a short complication, we can accommodate that. Then we can have some.
Why not? Why not? Because I think we all learn more from the complications than from a good surgery. So what I would like to say about this complication was, like Prof rightly said, why should not we go flush with the vessel, flush with the aorta when you're taking the IMA? Because in case you do land up having a clip breakdown or a clip, that comes off, then you're in real trouble. I'll just show you a small clip which happened not long ago, literally this week. It's still fresh in my mind. Let me just get to that clip in a minute.
Any that kind of experience, Prof, you had?
Yeah, if you do them long enough, you would have, of course. But like I said, initially, as the perception is that being away from the patient or a sitting console, you probably have less control. Contrary to that, you have actually more control because you are controlling the camera. Remember, when the bleeding happens, the picture disappears or the picture becomes that much crucial. So this is from the days of our laparoscopy even. I've always have maintained to leave a 2 centimeter stump, more so for the nerves, and secondly for this particular problem. Uh, you know, yes, of course, and then you deal with this by having an exposure in laparoscopy. You can put extra port in. It's the same thing in robotics. If you're having difficulty with all forearms, there is always a thought of asking your assistant to put an extra 5 port in a hurry. Don't forget about that. It's literally the exposure, because if you can see things, you can do it.
Okay, so this is a young 24-year-old girl. 24-year-old girl who came with weight loss and rectal symptoms. And it so happened that investigation suggested she had a huge rectosigmoid tumor associated with left-sided met onto the ovary and the tube, with a metastasis in the vesicular peritoneum as well as the recto-uterine pouch. We went ahead and did a robotic anterior resection, left-sided salpingo-oophorectomy, pelvic peritonectomy, and we actually managed to do a HIPEC as well with tailored cytoreductive surgery because of our patient's family's wish. So when we were almost finishing off the case, just about, finishing off the case, this is what I had to go through. So this is the splenic flexure mobilization we routinely do. Now I do always medial majority of it, get to the lesser sac, and then actually go supracholic as well as laterally. So when we were doing this, you suddenly start seeing things that you shouldn't see, a bit more redness in the area, and then you suddenly start seeing what else is going on in the rest of the field. So this was on the left side where we were on the splenic flexure side. And, we had taken the IMA down, we had put the clips on, and suddenly we started seeing some amount of blood oozing. And then you think, where is it coming from? Is it bleeding from the mesentery? And there we go. That is the IMA, which is bleeding. We had 2 clips on it, and I'm not sure whether it was my monopolar which was moving and got the clips off, or whether it was the instruments. Luckily, I think, as Prof had suggested, we had left a good enough stump. I think that was our savior for the day. I think this is the first time it has happened, and luckily I had a good assistant, and we took it with patience, and I think we managed to clip it and take adequate control, and eventually clipped it thrice, so that we are safe on that part. So I think now we have done about 40 resections all in all. Majority of them are left-sided. And have managed to have 4 complications, including this 5 complications. But there were not much of consequences. But the other 4 complications we have had, one was an internal hernia into that lesser sac, which we showed. One was a pelvic hernia because of an empty pelvis syndrome, and 2 anastomodic leaks. One was from a transverse colonic anastomosis, hand-sewn, and the second one was a low rectal in an elderly man whom I should have defunctioned. So I think this is our story of growth in Apollo Hospitals, Bangalore. So to me, I think we learn every day. I think we learn more from the mistakes. We learn more from our experiences and others' complications than good things. So I'm really grateful that I'm in an era where laparoscopy, minimally invasive surgery, has made a huge difference, and I'm really grateful that I've been under people like Professor Amjad Pervez and have colleagues around the world who are actually into this field, so that I can pick up a phone, ask for help, and move on. I think that's my side of the story when it comes to robotics and robotic surgery in Bangalore. Thank you, and I'm happy to take any questions.
Thanks, Gemas. Thanks. Now, I would ask the panelists to ask few relevant questions, please.
Right. Can I ask something to any one of you, really, Prof. Parvez or Dr. Narsima? Do you guys routinely take the splenic flexion down in case of doing a low or mid rectal cancers?
Yes, in my practice, yes. I think uh, there is never ever, as they say. But when we looked at our data, it's almost 99%. The population that we probably would not do this for would be the abdominoperineal resection for obvious reason.
Sure, sure.
Or I have learned as I travel that some of the Russian population have got very large descending colons. They are the one who hardly ever mobilize flexure, but that's the congenital problem, I think, or congenital advantage the surgeons have. But in Western Hemisphere, whenever you do TMA, you end up mobilizing the flexure as a default. So I do that at the beginning, which is like artery, vein, flexure before I come down to the pelvis, so I don't have to think whether I have to do it in this particular case or not.
So do it routinely.
I think to me, Robin Phillips, with whom I spent a long time, used to say, Simha, it is all about the lack of tension. Would you defunction an Altamaya? No, we don't. So if that is the case, if there is adequate tension lower down, you can be rest assured if the vascularity is okay, you should be okay. So I think that is one of the reasons I religiously not only mobilize the splenic flexure well, I try and see if I can intercept a segment into the pelvis. So that tension aspect is taken care of. So the answer is yes, every case I actually mobilize the splenic flexure.
Prof,
Yeah.
if I add to what Shidnath has said, see, I started mobilizing the splenic flexure routinely in all patients, but we hardly see diverticular disease. So now I've stopped. I go till the flexure, mobilize the entire left colon of the Geroda fascia, but now routinely I don't mobilize the splenic unless the sigmoid is rather small. I've changed.
Yeah. I think
Pradeep,
most of our practices is based around our personal prejudices and what the boss used to do and whom I train with. For example, historically speaking, people always had a no doing anastomosis on sigmoid, calling it a high pressure zone and leading to higher anastomotic leak or bad function. But we all have known now that is not the case. I think
Okay.
largely as the teaching come from the West, it came at the backdrop of a significant diverticular disease in sigmoid section of the bowel. I think that was more the reason we were looking for soft descending colon to join rather than the science behind high pressure zone. So I agree. I think if you get the similar outcome without having to mobilize or do it formally, as you call it, because you already have gone laterally, I think if you take the vein high and you've gone laterally and you've done this bit, this is usually good enough if you have a decent sigmoid. Uh, so it's horses for courses effectively.
Yeah. Prof, I want to ask you something very basic, sort of semantic. This ultra low LAR or low LAR, should we have this differentiation or no?
No, I think it's to do with the nomenclature. For example, as some of you would know that in Britain, private practice, all left-sided dissection are anterior dissections.
Right.
So
For views, yeah. That's true. That's true.
sigmoid colectomy doesn't
Yeah,
exist. I've never
yeah, yeah.
seen an operation called sigmoid colectomy in my
Absolutely.
career. So I don't think so there is a differentiation.
Exactly. And finally, when you put the staple, did you fire the staple partially and then open them once again? Is it one stapler, two stapler?
Now these are two firings of 45 millimeter stapler. So I
Yes,
fire all the way
that's fine.
to it halfway. Yes.
So unless you use 245, it's very difficult, actually.
Yes.
Minimum. Yeah. Okay. That's all from my side.
Shivnath, any more
Yep.
questions?
Um, on robotics, the conversion rate is low compared to the laparoscopy. That what the study says. Sometimes it's not statistically significant, but what exactly the difference in the male pelvis, big tumor, low tumor, low big tumor, and male pelvis? Is it a lot of difference between conversion in laparoscopy and robotics?
Well, I think the two-part answer to this. For example, if you ask me, the pelvis is a very consistent anatomy. Even in an obese person, you know exactly the goalpost. The thing which is hugely variable in all of the patients that we operate on is a splenic flexure. Either it is very easy or it is the hardest thing in the operation that you would do, particularly with SI system, the previous system that we had, where you could only dock and put patient in one particular position and it gives you handicap not to be able to move it. Most of the surgeons were doing what they used to refer to as hybrid robotic operation, where they would do the vessel and flexure laparoscopically and then dock the robot within the pelvis. Seema mentioned rollout trial. You'd be amazed to know that a significant proportion of those patients were done with hybrid technique. So, in many ways, that is not a true reflection of surgical skill, so to speak. Other thing you have to take into account is that early adopter for robotics are usually minimally invasive surgeons who are by default natural selection who are opted to do something different. So if I changed to robotics after 2013, I had a previous experience of doing more than 600 laparoscopic TMEs. So I brought that practice into a robot. So that has to be factored in. So when I tell you my conversion rate is close to 0%, that's not a true reflection. The idea is that if you give it to a novice and ask them
Yeah.
to show the difference, then it becomes a bit difficult to show the difference in short term. Eventually, the people would catch up. So, the second part of the answer is that the gains are there for obese patient, male pelvis, radiotherapy pelvis, for example. But this has to be taken in the backdrop of your prior experience of laparoscopy, your understanding of rectal cancer anatomy and treatment principles. Then, of course, it will become very obvious that conversion rate is low. Now, if you remember from our time in England, and this has not changed by the way, there is a term that I have been introduced to in England, and that was called laparoscopic, that was called lap assisted anterior resection
Yes.
rather than laparoscopic, which I couldn't figure my head around it what it is. And the idea really was that they say they had problems stapling it, so they would do the vessel and then they'll make a suprapubic incision, and then they carry the dissection a bit more further, and then they put a TA60, or there was that echelon gun, where they would just divide it, the long big gun in open surgery. And they said this gives me a more secure anastomosis. But effectively, this was the skill gap that we're referring to.
Now, can I ask something which is completely different from here? Are you now routinely using ICGs in Britain?
I'll let Simart speak to you, and then I'll give you my perspective. Otherwise, it will become a very prejudiced talk.
To me, I think I'll tell you. When I started, obviously my experience comes from Prof's work in Lisbon and somewhat Imperial. But I think there was a medical legal case in Britain, came from Colchester. Despite ICG, there was a leak and the patient died, and it was in the court of it was a medical legal case. And where I used to work, we used to have Jonathan, who was my clinical lead. And then when he went to the court of law, and when they looked through the data and the documentation, I think what saved the day was the use of ICG and good vascularity. So to me, it was just not about checking the vascularity grossly, but also looking at it, through an ICG and making sure, that the vascularity is intact. So I think these are the things which has tempted me to use ICG regularly. It costs about 2,000 rupees or 1,800 rupees, which is not much. And I routinely use for all my cases ICG irrespective. And especially more so when you're thinking about, should I take the ascending left colic or not? Should I take a high tie or not? I mean, let me give you an example. I had a case again last week, a big descending colonic tumor. So when I went in, I was thinking, should I take it very high, which means the anastomosis will be at sigmoid? How will the vascularity be? So on and so forth. So when I skeletonized all the vessels, ascending left colic, first sigmoid, second sigmoid, and then the rectal, then it was, you can just clip it and see the vascularity on the ICG. And I think it is a real joy to see how the vascularity is. So by default, I use ICG for all the patients. It's a matter of literally 1,800 rupees or something like that, and it gives you peace of mind. That's what I think is my opinion.
So I have a slightly different approach to it. So I'll ask you the question that before ICG came along, were all of our anastomoses were leaking, and since ICG has come in, have we stopped having the
No problem. I think there is technology
no
and
no?
it,
So I'll come to that. I know exactly what you're saying. So I'm not against anything. I am the guy who likes the change, right? But I have a perspective to it. For example, um, if you think about it, even in the presence of normal ICG, the leak happened in that medical legal case, right? And of course, it saves the skin of the surgeon saying, I did everything I can to make sure that it was a nice vascular bowel that I joined together. But the truth is, as a surgeon, we all know that leak is never a singular factorial reason for it to happen, and there's a number of contributing factor. So, I personally think that if you narrow it down and say, um, if you have access to technology, and you have got an operation which it has taken you long, and you are looking for what you call a reinforcement of your decision making, I think this is what it comes down to. As a surgeon, if you think about it, we do series of decision making during a singular operation, and a lot of these are actually high stressful situation to make those decisions. And if the technique or technology is there to help you sleep better, in terms of showing you a green bowel, hallelujah, why not? It helps. But, if I put all my faith into green bowel and have not mobilized the bowel enough, have attention at anastomosis, if my operation have become bloody, it has been a struggle doing this, and I have a mechanical problem at the joint. So ICG solely would not save me. That's what I'm trying to put across to you. So in my practice, particularly people where I would like to sort of use it as a backdrop, where I look for it and ask for it. Usually the anesthetists have given it already, and all you do is flick a switch on the robot and you can see it. Great, right? But if you specifically ask for it, they are diabetics, obese patient, and when you have divide where your intended line of transaction is, and you think, well, it looks okay, but it can be better. So you're looking for a reason to reinforce your decision making. Please do ICG if it is there.
Good. I think we are really half an hour past the time we had actually.
Okay.
But a fantastic meeting. I appreciate both of you taking time to discuss with us. I'm sure the surgeons in Kolkata, even other places in India, has been helped a lot by this. So thank you, Prof, again for your time.
Thank you.
And thanks, Sima, and thanks all the panelists.
Thank you.
I think Sunil is the COVIDian guys. They want to show something, a video or something. Sunil, hello, Sunil, are you there?
Debuda, can I just ask one question?
Yes.
Thank
I
you.
forgot it.
It was such a fantastic afternoon here. And Nashiba, thanks for showing your complication. I think one of the reasons that worked is because you were so calm. I think that was so crucial. That was really good. Prof, this is more a question because in your slide you mentioned, like a high volume unit and all, which I totally agree. Do you think in the colorectal circle that we should be thinking of subspecializing rectal cancers? Because I don't think rectal cancers is for all colorectal cancers. It's very different from colonic cancers. And I just wonder, whether we should be subspecializing within us the specialty.
Yeah,
What's your thought?
Yeah, it's a very relevant question, and it's the question that has been discussed in colorectal fraternity for a few years since we've been practicing. The problem is the relevance. We all seek relevance, and nobody wants to give away this relevance. Whether we are good or bad at it, it become almost immaterial. For example, so the fact that if I do pouches better than most of the guys, and there are only sort of half a dozen or 1 dozen pouches in the unit to do, we would never come to a consensus where the surgeons would say, I'll give it to Pradeep because he does it better than anybody else, because it's the relevance question. But if you go beyond that, then of course, there is a very strong case to have what I call subspecialist interest within the specialty. And, and actually, it is happening, if you notice, by default. Within the unit, some people do pelvic floor, some people do IBD work, some people do cancer as a generic term, as you call it.
Yeah.
But I think when we would have what I call regional services, rather than using like Winchester giving up their rectal cancer to Southampton, that is not likely to happen because there is a kudos involved in this. But I think the argument perhaps would come at the back of population base, the way they did it for esophagus and pancreas, for example, in England, as you know. They make it like a million population base, and then they have a regional rectal cancer center. I think it would evolve. It would be good long term for our patients because, like you rightfully said, it is a slightly different beast. It is not just being able to do the operation, it's about managing the problem that come with it when the recurrences happen. As we know, in England, we have subspecialist recurrent cancer centers. So people go to certain places because, this is how it has evolved. So I'm sure it is only a matter of time when, the big B's and E's and authorities, whoever makes the decision, sit down and say, we're going to make it regional center for rectal cancer. And then that would deliver early rectal cancer, recurrent rectal cancer, robot, radiotherapy, TNT, whole aspect of that, rather than just one aspect as in TME.
Okay, thanks very much. And I think the Medtronic guys has got some few more slides to show us. So it's up to you, Prof, to keep online or if you want to switch off or whatever.
All right. Well, thank you for having me. I really enjoyed being here and seeing some familiar faces and names. Thank you. I'd love to come back if you want me to come back ever in future.
Thank you.
All right.
Thank you, Prof. Thank you.
Bye-bye.
Thank you, everyone. So, shall I begin, Dr. Dikmar Ring?
Yes.
Thank you, Dr. Ray. So, hope everyone can see my screen. And I'm Lakshay, and I'm from Medtronic. Welcome, everyone. And I know it's almost too late in the night, and I'll just quickly try to show you what are the innovations that we have. I'm sure I've just tried to include all the different things that we have from Medtronic. So as you know, that Medtronic always has had a very, very rich history of innovation when it comes to stapling. What I actually want to share here is the powered stapling. It started from 2012, and in 2017, we have Signia. Now, I will be talking more on Signia in my next slides, but between these powered staplers, you will see we have different generations of tri-staple technology. And I'll just start with the tri-staple. So tri-staple, as you can see, is basically not just 3 rows, it's more than 3 rows. And it is actually 3 staggered rows. And the outermost row ensures that there is very, very less stress, and then there is more perfusion to the tissue so that the necrosis, the chances reduce, and the chance of anastomotic leaks also reduce. And the best part is it is also quite smooth on the variable tissue thickness. So very happy to share that tri-staple is one of the leading reloads in India today. The next is tri-staple specialty. We have the radial reload, as all of us were talking about colorectal today. So we have for LAR, and then this is the first reload, which is in tri-staple, which is radial in shape. It ensures that we reach deeper, at least about 2 centimeter. Then we have EGIA curved tip. This is good for tight spaces for when you want to put it on ducts, or let's say if you want to take smaller vessels. I'm sorry. Then we have black, which is good for rectum, pylorus, or bronchus, or any other thicker tissues where you want to ensure the staples shouldn't come out. And then there are also slimmer profiles of 30 mm reloads for vascular or tight spaces. Then we also have for buttress material. This is the PGA material tri-staple reload. So actually, there's a host of tri-staple specialty reloads apart from the normal linear reloads. Now this is the gun. As all of us know that this is one manual gun. The best part is more than 40 reloads can be attached. So one gun, anything under the sun that Medtronic has launched in the last 20 years, any color. The best part is any color, any size, any shape, anything will go with this. Then let's talk about Signia. Signia is the talk of the town in India today. And so, yeah, first gun, powered rotation, powered, everything is powered. So rotation, articulation, firing, jaw opening, closing, everything is powered. It's smart. So, it senses the tissue, and then it decides how fast or how slow it should fire, something that is not capable with a normal manual gun. So if it's a very thick tissue, it will take 18 seconds. If it's a thin tissue, it will take maybe 5, 6 or 7 seconds, and it actually tells us on the screen that which zone this is going to fire in. So these are the different zones, and it's actually smart. So it's got a brain inside the stapler. And now the biggest thing is this, I just love it. 300 cases, and one gun, you just put it on smart charge. It's like, one of those cordless phones. Yeah, you just simply put it on a smart charge, and it'll just charge within 3 hours, and you can run for up to maybe 18 hours in full charge. And 300 cases, one gun, and you'd have to maintain all those SQs. Real-time feedback is there on the screen. And yeah, more than 50 reloads. That's the best part. Signia, there is no special reload. It's all of this is compatible. So any color, any size, any shape, that's the best part with Medtronic Signia or the gun. Now I'll quickly switch to open stapling. Well, this is the GIS staplers that we have, and we are proud of the DST series technology. The next one is the hemorrhoid stapler. This has a detachable end mill, something that is not there with any other company. So the detachable end mill technology. And then we have DST EEA stapler. Now this is the 2-row circular stapler that comes with the tilt-tipped top mechanism. Now comes the big thing. This is what we have recently launched, and something that all of us are really, really proud of. In fact, this is a global launch this year. EA circular stapler with tri-stapler technology. Now this is the first circular stapler that comes with 3 rows and tri-staple technology together. And the best part is that the lumen doesn't change. So the inner diameter of the lumen will not change if you're using the same 28 or 28 or 29, 29, 31, 31. The inner diameter will actually remain the same. Now this is just a graph that tells us that if you see number of staples in tri-staple, let's pick 31. So it's actually 45. If you see our 2 rows, it's actually 30 staplers. And if I just talk about, let's say, Ekicon's 29, so it's actually 24. And if I talk about our 28, it's 39 staples. So imagine 24 and 39. And the biggest part is the inner diameter remains the same. And all the surgeons are also loving its audible as well as the tactile sound. I just quickly move ahead. Now we also have a DST-TA stapler. This is a stapler that doesn't cut. It doesn't have a knife, but it just staples. The best part here is it's very, very cheap in terms of its reloads, and it's got 2 rows in it. Now the trocars, our trocars are universal in nature. It's just one cannula and all 4 obturators. And I have absolutely love this fact that our trocars in all the MNCs are very, very competitive in prices. I would say somewhere between 4,000 to 5,000 rupees. These prices are for each of the trocars. It is not like 7,000 or 8,000. Well, and then Surgisleeve is also within India now. 5 different sizes. I have, we actually have a lot of surgeons in India who are using Surgisleeve in LAR procedures. It ensures that there is no problem of continuous retraction. It ensures retraction. It ensures that the peritoneal surfaces are nicely covered, and the wound is quite exposed. So the wound exposure, the peritoneal surfaces are quite safe from the cancerous tissues, and then the retraction is there. The best part is the price. It's just between 4,000 to 6,000 rupees depending on which sizes. In fact, the largest size is used to deliver babies as well. So it's used in there. Finally, endo hand instruments. We have premium surgery clips. It's an open clip applier. It's got preloaded clips. You can easily count it. You don't have to continuously take out the clip applier and then load one clip and then put it back inside. It's got all the clips loaded. It's got ratchet mechanism. It's got tactile feedback. It's got audible feedback. It's got a visible indicator which tells you that how many clips are remaining. This is the best part. This is just a 5 mm endo clip applier which has got 16 clips embedded in it, and it's integrated. You don't have to take it out every time, and it tells you on the LED screen how many clips are remaining. As you can see right now, it shows 16, so it goes from 16, 15, 12. This is also available in India, and we're really proud of this product. Now comes the magical product. This is EndoStitch laparoscopic suturing instrument, a very very unique instrument which can go through 10 or 11 mm trocar, and it does the job of laparoscopic suturing quite nicely. And I just go to the next. So we got EndoCatch Gold device. I'm just towards my end of my presentation in next 1 minute. So EndoCatch Gold device is also available. It's got a continuous ring inside with a very very large volume. Very very convenient in using various kinds of tissues if you want, if after the resection, if you want to just remove them out, appendix, gallbladder, and others. Medtronic also has in India a big series of graspers with the different kind of tips. If it's a very very big lung, then there is endo lung, or there is endo Babcock, or endo grasp, endo clinch. So there's a series of graspers. Then there is series of scissors. Now this scissors also has a unipolar cautery capabilities. Then we have dissectors also. Now these are the dissectors. All of them are fantastic 5 mm ones and with different dissection capabilities. Now comes the product which not many people are aware. I'm sorry, many surgeons are not aware, which is anti-fog solution. Very cheap product, maybe just 400, 500 rupees. And you can just put few drops on top of your the scope, and then there will be no fog, and you don't have to continuously clean it. So that's the magic behind this anti-fog, and that's it. Thank you, everyone.
Thank you, Lakshay. That was good. And I recently used your the automatic endo-GIS stapler one. It's fantastic.
Signia.
Yeah, Signia.
Does the anti-fog really work?
I'm sorry.
How effective is the anti-fog solution?
It is.
Honest, I have used it in UK. It was readily available. The Defogo or this one.
Anti-fog. Yeah, I'll just go back. Yeah.
Is it really effective? That's what I want to ask.
Good. It is good. It is good. Fred is available here.
Yeah.
Okay.
Yes, sir.
Okay. I think we'll conclude. Thanks, Manas. Thanks, Simna.
Thank you.
And I think we had a lovely discussion. So we will carry on almost every Saturday with some other surgical problems for next few weeks.
It was really good. Really good.
Okay.
Thanks.
Good.
Thank you, Dr. Mandal. Thank you.
Thank you very much.